And then I'm going to share my screen. And we're talking about autism tonight. Let's see. I'm going to share this PowerPoint. I don't know if that worked. Can y'all see my PowerPoint yet? I don't think you can. I don't think I did that right. Let me go back.
No, ma'am, it's still on the Microsoft Teams screen.
Okay, that's what it. Do you still see Teams now?
No, it's
No,
back on
ma'am.
all of us.
On all of us. Okay. Let me try it again. Okay, here's what I want to do. Share. Alrighty. Our chapter tonight is about autism. And I think I'll do the slideshow tonight because the last slide I want to show is actually a video. Oops. Okay, I thought I had taken these to, yeah, there we go. Okay. Nope, I'm gonna back up. Okay, the term autism was coined in 1911 by a Swiss psychiatrist named Eugene Bleuler. And so that was the first time that the term was actually used. It was then used again by Leo. It looks like Kanner, but I think they actually pronounced it Kanner, I believe. It was an Austrian or a German psychiatrist, psychologist, one or the other. Your book talks more about this, but it's not pronounced the way it looks. The people in Europe were the first ones to do a lot of research on autism, the Germans and the Swiss and the Austrians. I think that that they really made a lot of strides in this field in that part of Europe around the 1930s and into the 1940s. Lots of advances were made, and in 1943, Kanner described 11 children in a study that he did with similar characteristics, and he called it early infantile autism. And it's what we today would consider to be really severe autism, not what some of us would call higher functioning autism. And we're going to talk about that a little bit as we go along today. But the characteristics included onset before age 6, and that's pretty typical of autism in general. We really do want to see the characteristics appear in early childhood before a child reaches school age. Sometimes we identify autism after a child gets to school, but not generally. It usually happens at the age of 2 or 3. If we don't recognize autism until a child is in elementary school or later, then my alarm bells tend to go off. Maybe it's not really autism if we're not noticing it till later, or if it is, it's usually very high functioning autism if it didn't show up in early childhood, because that's one of the hallmarks of autism, is that we see it and it has onset in those early years. Usually the child has what we consider excellent rote memory, so they can recall things very readily when it's relying on just that immediate recall of something. They exhibit what we call echolalia, and that is repetitive speech that they've just heard. So maybe they've heard something on television, a catchphrase on television, maybe a commercial or something, and they'll repeat that catchphrase over and over and over. Almost like a mynah bird or a parrot that just repeats a given phrase again and again and again that they've heard, not without a lot of purposeful meaning to that phrase or those words. A lot of times they can recite the alphabet, they can say their numbers in order, things like that that they've been taught, but they don't attach a lot of meaning to it. There is an insistence on sameness. They really find comfort in routine and things being exactly the same. And sometimes they're very upset when things are changed. So any movement out of a routine can be upsetting. They often have an inability to relate to others and situations in a normal manner, what we would consider typical of other children their age, and they exhibit a desire to be left alone. So they really thrive on solitary play, just being left to their own devices, and they can sit and entertain themselves oftentimes for hours on end. This was first acknowledged as a psychiatric disorder, as a standalone psychiatric disorder in our country in 1980. And that's really recent in psychiatric terms, in terms of a disorder. And then first considered as a disability under IDEA in 1990. And it is the most recent of the disabilities that we've added to IDEA. That's been within my career. So there are 5 spectrum disorders that fall under the overarching umbrella of autism. And we now call them autism spectrum disorders. And we just had this broad category called autism. And this has changed a little bit in the last few years. We have this book that I think I've referenced a time or two called the Diagnostic and Statistical Manual. And it's the book that psychiatrists and psychologists use to diagnose psychiatric and mental disorders. And it's updated every number of years to kind of get in keeping with what's happening in the field of research. And we are on the 5th edition of that book presently, and it's now the DSM-5. And when it was revised and published again in the 5th edition, autism was an area that was particularly readjusted. And some of you have probably heard of Asperger's syndrome, which was for a long time considered high functioning autism. It was taken away as a separate disorder and put back under this umbrella of autism spectrum disorders. And so now they're all just called autism, and we don't have something separate called Asperger's syndrome. We just have autism. But I don't think anybody would disagree that there are variations in the autism spectrum. There are lots of different ways to be autistic. And so I think that's why we call it a spectrum disorder, because there are lots of different types within that umbrella. And I don't think anybody would disagree with that. There's a quote in a video that I usually show during the face-to-face version of this class, in which a man who is a professor at Adelphi University in New York State, but he's also a person who has autism. And he says, if you've met one person with autism, you've met one person with autism. And I think that's a great quote. If you know anybody with autism, if you know more than one person with autism, you would probably agree with that, because autism is a disorder that looks very different from one person to the next. And so we have, first of all, what we would typically just call autistic disorder. And that shows us generally disruptions in social interaction, communication, and restrictive or repetitive behaviors. So when we start looking to diagnose autism, those are the 3 areas that we look for. We look for social interaction or a lack thereof. We look for disruption in communication, and we look for these restrictive or repetitive behaviors, like the hand wringing, or rocking back and forth, or those any type of repetitive kind of movement or behavior that stands out as really atypical. Um, so those are the three hallmarks of the autistic disorders. So then the next thing we see on our screen is Asperger's syndrome. And this is no longer listed in the diagnostic manual as a standalone disorder, as I said a moment ago, but it would be what we consider high functioning autism today. And you probably have all run across somebody in your personal life who has Asperger's syndrome or high functioning autism, whatever we want to call it. Because sometimes these are the people who are very successful in schools, but they're kind of quirky, and usually they're not nearly as successful in their social relationships as they are in their academic settings. So socially, they're awkward. They don't fit in very well socially. They don't know how to interact with other people socially. Their communication might be abrupt. It might be awkward. They're not usually hung up with this restrictive or repetitive behavior side of things. Sometimes they do have some OCD tendencies, um, um, some ways of wanting a certain type of order in their lives, but not to the degree that we would call it really life altering. So that high functioning autism impacts people in a way that usually they're socially impacted, but not so much in a lot of other ways of daily life. Usually they can live independently. They have success in their professional lives. A lot of these kind of people are very successful in the STEM areas, math, science, engineering, those areas. The next one that falls under this umbrella is what we call Rett syndrome. And it's a very rare disorder that falls under the autism spectrum. It's found in females. Typically, people who have Rett syndrome develop, as we would expect, until 6 to 18 months of age. And then there appears evidence of hypotonia. That is a lack of development in muscle tone. There's reduced eye contact, decelerated head growth, and kind of an overall disinterest in play activities or general interaction with others. Then what we see is a rapid developmental regression. The things that the child had attained, as well as far as milestones in development up to that point, begin to recede. The hand wringing starts, unsteady walking, breathing irregularities, and then feeding and swallowing difficulties. Language development either stops or regresses, and then seizures develop. So this is a really tragic kind of disorder that falls under the autism umbrella. The next one is childhood disintegrative disorder. Kind of hard to say. It's also very rare. Also, the child is typically developing during those first 2 years of life. And then regression sets in. It begins between the ages of 2 and 10. And affected areas include language, social skills, functional behavior, bowel or bladder control, and motor skills. Somewhat similar to Rett syndrome, except this can impact females and males. And all those other characteristics of autism that I mentioned a few minutes ago are also present here. And then we have what we call pervasive developmental disorder, not otherwise specified. And that's a really long name, so sometimes we just abbreviate it, PDD or PDD-NOS. And this is a disorder that's kind of like autism, but not usually quite so clear cut. And so it's diagnosed when a child displays some, but not all of those characteristics of autism. And so the clinician, the psychiatrist or the psychologist, whoever's working to make that diagnosis, doesn't see everything that they would expect to see for a clear cut autism diagnosis. And so they go with the PDD NOS instead. So how widespread is autism? Well, there's a whole lot of disagreement about this number. Autism is the most prevalent of the spectrum disorders, and we have about 10 per 10,000 births. Now, there's been a lot of disagreement about how many kids have autism in the general population. And some would say that it's about 1 out of every 250 births. Others would say that it's 1 in every 50 births. I tend to be on the more conservative side of that. I don't think it's nearly as widespread as some people believe it to be. I think we have an overdiagnosis of autism right now. I think that maybe some kids who have just some developmental delays are being pegged as having autism. Some kids with some communication disorders are being pegged as having autism. Some kids with some social and emotional difficulties are being pegged as having autism, when it really doesn't rise to the level of true autism. About 0.29% of children with disabilities in the school age population do receive services under that AU, or what we would call the AU is the abbreviation, or the autism category through IDEA. So not 1% even, less than a half of 1%. The category, though, is increasing with about 10% annual growth. Now, there is a gender prevalence. More boys than girls are identified in this category. So what causes autism? Well, nobody knows. Some would attribute it to psychological factors. There's been a big push in the last few years to environmental factors. Is it something in the water? Is it something in the diet? Is it something in vaccinations? Is it something in the paint on the side of the crib? All these kinds of things. And there hasn't been anything that's been proven in the environment to cause autism. Now, this video that I ordinarily show during the face-to-face class spends a lot of time on this, and a lot of the theories behind some of this. The video that I show is called "Loving Lampposts," and if you get a chance to watch that on Netflix, it's a good one, and it is available, or at least it has been available on Netflix. Now how they take things down off of Netflix with some regularity, but you might try and see if you can find Loving Lampposts on Netflix or one of the other streaming services. It's a really good look at. It's an overall look at autism, and some of the theories that people have put a lot of energy into. Trying to nail down what's going on with it, and even trying to remediate autism and get rid of it in kids. I'm not of the school of thought that you can remediate autism away, but it's interesting to read about people that do believe that. Many of you probably know or have seen Jenny McCarthy. She was real popular back in I guess it was probably the 90s on MTV. She was a VJ on MTV back then, and now she's regained some of that popularity on this Masked Singer show. She's one of the judges on that, but she had a child with autism. I believe it was back in the 90s, and she decided that the cause of that was the vaccinations that the child had been given, and she went all over the media touting that theory. And there was a man in England, a physician in England, who had written a research paper about that very theory, and it got quite a bit of traction because it was published in one of the journals in England that gave it some credibility. Well, over time, that theory was debunked. That particular doctor, and I can't remember his name right now, was called forward and was questioned at great length about his research, and he even admitted eventually that he had made up his entire study just for the publicity of getting published. But the theory, even after he admitted that his research was false, the theory continued to thrive. It just kind of goes to show that it's real hard to put a lie down once it's been propagated widely for a long time. And so there are still a lot of people that believe that a vaccine can give you autism. There is absolutely no proof to that whatsoever. And the person who said so in his research has admitted that the research had no basis in fact at all. But there are still a lot of people who don't want to give their children vaccines because they fear autism. We don't know what causes autism, but our third bullet here does give us some links to possibilities. Autism does seem to run in families, so there may in fact be a genetic factor at play. We don't know this for certain, but you will see autism in families. I've read some stories of a number of families, and this is anecdotal evidence, but several families, and I've seen them in schools where I've worked, where you'll have a family that has maybe 4 children, and 2 of the 4 have autism. It seems very suspect that would fall to just chance. And so more research needs to be done on the genetic factors and the biological factors, but and that continues to be something that's being researched. But I think that that all of these are still questionable as far as what the actual causes of autism actually are. So what are those general characteristics? Well, again, the primary 3 are disruptions in socialization, disruptions in communication, and disruptions in behavioral elements that search by the individual for repetition and other kinds of behavioral movements and actions that are out of the norm. So that's what we want to look for. What we don't automatically have in people with autism is intellectual disability. Now, does it occur with people with autism? Yes, it does occur. Sometimes, even most of the time, but not all of the time. Certainly not with people with high functioning autism. Oftentimes there, the IQ is very high. But with typical cases of autism, run-of-the-mill cases of autism, and certainly those that we talked about earlier, like Rett syndrome or childhood disintegrative disorder, in those cases, the IQ can be very low. But just typical cases of autism, not high functioning, or what we would have called Asperger's, the IQ typically is lower than average. there is difficulty with what we call executive functioning. And that is the part of the brain that works with planning, um, and attention and short-term memory. So just kind of setting up how the individual is going to um, make their way in the world. So when those kinds of things break down, it's really hard to go about as a typical individual. Um, when your executive functioning is not working at its full capacity. So that's what helps you know, okay, when I get up in the morning, the first thing I need to do is, you know, um, get my clothes on, brush my teeth, have my breakfast, get my backpack, get out the door to my ride to school. Those kinds of things. That's all executive functioning, the planning of what's next. Where do I keep the things that I need to do the next task that I have on my agenda? Once I get to school, what are the things that I need to do first? I need to go to my locker. I need to get the things out that I need for my first period class. All of that is executive functioning. Where is the bus stop? How do I get there? All of that, executive functioning. And then the things that keep you from doing things that are too um, without that are too um, too impulsive. Your executive functioning keeps those impulses in check. The next one here is deficits in what we call theory of mind. And we've talked about theory of mind once or twice, I think maybe this semester. And that's thinking from the perspective of others. So that empathetic mind, being able to put yourself in the position of somebody else and think, how would that make me feel if I did that? If I were on the receiving end of this behavior. And that's something that people with autism or a lot of other kinds of disabilities that impact our intellectual functioning really suffer from. They have a deficit in that theory of mind. They can't put themselves in the position of someone else in order to take that differing perspective. They do usually have strengths in visual skills. And so when given something that they need to memorize visually, they're very good at that. So how do we identify children with autism? Well, it usually begins with an early screening. Like I said, most cases of autism have onset by the age of 2 or 3. And so when our schools offer screeners for our preschoolers, oftentimes those children show up for those. If not, they may have already had a visit to their doctor when the mom or dad think that something is going on there that's atypical. If the child is not the firstborn, then the parents have already seen what typical development is like, and they've probably already seen their physician or a psychologist or psychiatrist in the community who has said, yeah, something's going on with development here. Sometimes when we see kids come into the school setting at, 4 years old, maybe even 5 years old, and they haven't been identified yet, is where they're the firstborn child and mom and dad don't have a lot of opportunities for comparison with other children. If they don't have cousins or a lot of playmates, or they're not going to daycare, where they have a lot of opportunity to see what development is like in other typical 3 or 4 or 5-year-olds, then sometimes they come to school and haven't had that chance for comparison. So then we make a diagnosis. Like I say, sometimes that happens in the community, at a clinic, at a doctor's office, at a psychologist's office, psychiatrist's office, or it could happen in the school setting. And when it does, the school psychologist is the one to make that diagnosis. Now, we oftentimes have an autism team who works together to help make that diagnosis. And we may have a speech pathologist on that team. an educational diagnostician, an occupational therapist who's looking at fine motor movement. The speech pathologist is looking at the communication element of this. The occupational therapist is going to be looking at those repetitive movements, that kind of thing. The diagnostician would be looking at intellectual development, but ultimately the school psychologist is the one who hits the button and says, yes, we do have autism. So how do we instruct children who have autism? Well, first of all, the most important thing is we want to have early intervention. We want to get involved with the family at the very earliest point, because the sooner we get involved in the educational process with children with autism, the better off we are at attacking some of these things like the communication issues, the socialization issues. The second bullet you see here is applied behavior analysis. And this is an approach to working with children that you're going to see in a few minutes in a video that I've got for you. That is a method that a lot of parents of children with autism tend to favor. And it's one that schools have gotten much better at working with children who have autism. A lot of parents access applied behavior analysis in the community first, maybe have an applied behavior analyst come into their home and work with their child. And when they see success, they want that same service in the schools. And schools have gotten better about working that into the plan for children with autism in the school setting. We want to be working with communication to make that a better system for children with autism in the school setting. And then of course, let that bleed over into the home and the environment and anywhere else where the child finds himself. So we want that communication to be give and take. Oftentimes kids with autism, just really want to be by themselves a lot. And they don't really feel the need to have that interactive back and forth kind of communication with other people or other children. And so we want to work on that, developing the communication itself, and then the give and take of communication with other kids, with adults, teachers, etc. As I said before, socialization is one of the hallmarks of autism, or that lack of socialization. And so that's one of the other things we want to work on right off the bat, is having the child with autism have more social interaction, more opportunities for social interaction, and then to raise that level of socialization so that they are interacting more appropriately with other children, with adults that they come into contact with, teachers, administrators in the school setting, therapists, and so forth. They often thrive in that highly structured setting. And so we want to make the classroom setting and any place where the child finds themselves at school as structured as possible. So when they walk in the morning, they know exactly what they need to do, where they need to go in the room, what they need to get their day started, and then what to expect next in the day. Oftentimes children with autism are really distressed when the schedule isn't followed. And so when it's a day when there's going to be a pep rally, or when there's going to be, something special happening, a special speaker or something for the kids, or it's a rainy day and we're not going to go out to recess, or lunch is going to be at a slightly different time. Those kinds of issues really can be disturbing for a child with autism. And so we want to work hard to steer around those kind of events and prepare the child with autism to meet those changes in a real calm way, so that they're not too upsetting. Most kids with autism work really well with a visual schedule. We said a few minutes ago that they do well with visualization. And so if we give them a visual schedule, that's like a calendar, but maybe it's a picture schedule, or it may even be with words that says, here's what's going to happen next. Here's what happens at 9 o'clock. Here's what happens at 9:30. 10 o'clock we're going to do this. 11 o'clock we get ready for lunch. 11:10 we go to lunch. We finish lunch at 11:40, and then we're to the bathrooms next, and then we're back to our classes. And something that's a very laid out visualization of what the day looks like. And then sometimes even if they can pull those events off of a Velcro schedule and put them away, and then at the end of the day restructure the schedule for the next day, so they know exactly what's going to happen day after day. And that keeps them on track and helps them process each event that's going to take place. Social stories, we've talked about this a little bit with our students with emotional and behavioral disorders. They work just as well with students with autism. We write a story that tells about an event that's going to happen for them and how to work through that socially. Maybe it's about another student or a make-believe person and how they handled a change in their day, or an interaction with another person, or playtime with 3 kids, whatever the challenging situation might be. And that story creates a scenario that the child can hear about, learn about, and then hopefully place themselves into that situation. And when it comes up for them, they know how to work through it. So here's this video I want us to watch together. It's less than 10 minutes long, but it's a good visual of autism in general in a classroom, and applied behavior analysis in particular. So let's see if we can get it to come up on YouTube.
So I'm just going to put some under my eye here.
She's going to get her makeup on first.
By the results of the quiz.
Let's see. I want to skip those ads. Okay.
Most often, parents already know that their child has autism. They're just waiting for an expert to sit down with them and formally diagnose it. There are times where a parent doesn't know that's going on and comes into the appointment unaware of what it's called.
Can y'all see this?
Now we just have one diagnosis called autism spectrum disorder. Previously,
no, ma'am,
broken up into succinct categories, and the categories were
Okay. How about now?
to help people understand different levels and different functioning
Yes,
levels
ma'am.
of kids
Okay.
and persons with autism. Now it's all one disorder, and then we talk about different severity levels and functioning levels.
Autism is sometimes the A word that you don't want to hear it because you think it's going to be terrible, but autism is a spectrum, and there are children that have just a little bit of autism and who are in the mild range.
So a low functioning person on the spectrum would have intense behaviors that are impeding their ability to be independent in their life, little to no communication skills, unable to interact with other people and their environment without additional supports. Then you're going to have the higher functioning level spectrum. So in the past, it used to be called Asperger's disorder. People who have more of the stereotypic behaviors, repetitive interests, but their communication skills are there. They can communicate with other people. They can interact with others, but they still have some challenges and some barriers in those areas.
So difficulty with socializing with other kids, repetitive behaviors, such as toe walking, rocking, spinning. Those are the classic signs. The kids who are classically autism, you can almost diagnose right in the waiting room as soon as you greet them. They're fairly obvious. And pediatricians are generally good at identifying those.
If they're a young child, some of the things that you want to look for are a lack of eye contact, lack of being able to engage in pretend play. So for example, if you have a toddler and they are not interacting with baby dolls, they're not really using them to try to play, pretend to rock them or put them to bed. Another one would be social interaction. So oftentimes they prefer to be alone as opposed to be with other people. They don't start interacting with other kids. We call that parallel play, moving to more of an interactive play. They prefer to just continue to stay solitary.
Many kids with autism spectrum disorder have these heightened sensitivities to things tactile, things auditory, things olfactory and thermal. And as a result of that, they often recoil from situations and develop an intolerance for being in certain places and in certain environments. And the reason many of these kids have food-related issues is because of sensitivities that they have from an oral standpoint. They can't tolerate various textures in their mouth. They can't tolerate the smell of food or even the taste of food, for example. So those would all be some early indicators.
I think parents are afraid of the label of autism sometimes and afraid that this is going to change the course of their child's life. And really, I've had no one come back and say they wish they hadn't labeled their child autism, because in beginning to accept a diagnosis of autism starts the therapy for it. So it really opens up their world. It doesn't close it down.
The origins of ABA therapy harken back to the research of a groundbreaking psychologist by the name of B.F. Skinner. Dr. Skinner believed that behavior is changeable through positive reinforcement. Skinner found through his research that we all learn through the consequences of behavior. Behavior that is reinforced tends to rewire us and becomes our default behavior. He also found that behavior that is not reinforced will dissipate over time. Skinner's research is commonly seen in every one of our lives. As children, we learn to walk, talk, and avoid picking up hot things through repetitive training from our parents or loved ones. We learn most of our basic life skills through repetitive reinforcement. Reinforcers are essentially the outcomes of the rewards or consequences from our own behaviors. For example, rewarding a child for cleaning his room with money is a positive reinforcer. Cheering a child as she takes her first steps conveys to the child that the awkwardness of her first steps is worth the risk. ABA therapy simply expands this training in intensive ways until each child struggling with autism reaches new milestones and develops the habits he will need to live a full life as an adult.
ABA therapy is changing behavior by looking at what is reinforcing the behavior. So things that happen after a behavior occurs, where you can either expect that behavior to continue or expect that behavior to stop. And we look at the principles of learning in how we can change that behavior. So can we set up specific environmental situations, we call those antecedents, to ascertain a specific behavior? And then if the behavior happens that we want, how do we reinforce it so that we can expect that behavior to occur again in the future?
They have the way to help kids with autism down to a fine science that has little tiny goals that get added together to take a child from not being able to interact with other kids, being focused on their own internal world, kids that can tolerate other kids, can be at school, can follow circle time, can answer questions for you, can get their needs met, can communicate. And that doesn't come from broad sweeping goals. It comes from this daily battle with these kids with tiny little goals.
Let's say we were trying to teach a child colors, and we've got some different objects out for them, and we're trying to teach them which one is the red object, and they just keep picking the yellow one over and over. So there's different principles of behavior, there's different learning strategies that we may use where we elicit the behavior that we're looking for, we elicit the response that we're looking for. So we may move the red apple a little bit closer to them. That would be one type of prompt that we could use. And then when they pick the red apple, that's the red object that we were looking for, then we would give them some kind of reinforcer. It could be praise, it could be a high five, it could be something that they like, an edible item, it could be a toy for them to play with, something to let them know that the behavior that they just had, or the response that they just gave us, is what we were looking for, and that's a good thing. And then we would expect, based on that principle of reinforcement, that the next time that we ask them the same question, which is the red object, that they would be able to give us the correct answer.
So they're going to first, be able to point to a choice between two objects, and they're going to be able to point between two pictures of what they desire. Then they're going to be able to say one of the words, and they're going to be able to request one of the words. And that process takes weeks to develop, but if they can slowly work at it, they'll get the child there. So at home, parents can be frustrated for years that they can't understand what their kid wants. They can't communicate with their child, and they don't have the time and the expertise to know what are the little steps that their kid needs to make to get there. ABA therapists know that and have the time, because it is one-on-one therapy at such an intense level. They get the child to where they need to be, which seemed impossible before ABA existed.
And it doesn't matter, whether an individual has a physical disability or a cognitive disability, that they're not diminished in terms of value from anybody else. And I think that just becomes something so critical to keep in mind daily. As you're interacting with individuals, is the preciousness and the beauty of a life, and just communicating that value to them in every possible way, and communicating your understanding of that value to your community is just critically important.
Okay. So that's the end of our PowerPoint and the end of our video. Anybody have any questions about autism? The primary markers are deficits in socialization, communication, and repetitive movements, or other kinds of behavioral abnormalities that are not typical for a child of that age. Anybody? Okay. Any questions? If not, Riley, do you have a question?
No, ma'am.
Okay. Then we're done tonight, folks. And I'll post the PowerPoint and the video and the discussion here in the next little bit. And I'll see y'all soon. Thanks for attending.
All right. Have a good night, Mel.
Thank you. Y'all too. Bye-bye.